I go on placement in different areas, I can see there isn't any board that will give that information to the staff and also people who want to approach to the improvement. So maybe these kind of things will be helpful, especially at the entrance. Yeah.
Thanks, Nisha. I'll take that on board.
Thank you. That's great. Karen.
Hi, I'm Karen McConnell. I'm one of the non-executive directors. It was a truly interesting story. You've done incredibly well, I think, and it is quite inspiring. So thank you for that. I was really interested in what you had to say about Parkinson's as well. And when it comes to our improvement as a trust, have you got any sort of overarching thoughts on what we could do to perhaps improve the experience of people who come into the hospital with Parkinson's?
Yes, I just think, for example, booklet information can be given for the patients and also for the family, and maybe also for the staff, like on the board, it will be helpful if some prompt of some ideas about when the medication is to be given on time, or also to inform the families, or to remind also the patients, because there are still a little bit of further supports that the patients with Parkinson's might need, but a booklet where they can find, okay, this is your booklet, this is the hospital, this is where you are, which ward you are, this is the contact, the Parkinson nurses, the Parkinson champions, what support you can have, who to contact. It might be helpful also for the family. We have few for other things, like for tissue viability we have, for stroke, but I think for Parkinson will be helpful where all the information can be gathered, and maybe in an easy reading format. Will be helpful also.
Well, I think that sounds a really great list, and I'm just looking across on my screen at our chief nurse Teresa. I can see her nodding, so I'm sure that will be picked up. So thank you very much, Anisha.
Yeah.
Absolutely, and it's great to see such really, really helpful and constructive and practical suggestions. Really good. Does anyone else have any further comments or questions for Anisa? I don't see any other hands. Anisa, just to say again, thank you so much for joining us, and thank you for coming. Thank you for coming to join us at this trust, and really just by what you're doing, showing, hopefully encouraging your colleagues to say, well, if Anisa could do it, I can do it too.
Can do it. That's it.
And that's such an important thing. So congratulations on everything that you've achieved. We know that has not happened without a vast amount of hard work and commitment and focus. So congratulations on what you've done. We really look forward to watching your career as an RN going forward. And we look forward to you really, please keep involved with the production system and improvement programs, and keep involved with all the projects you're doing, because we need people with your sort of clarity and understanding of what's going on the ground. You're exactly the kind of people we want to help us with this. So thank you very much for joining us today.
Thank you. And I hope the organization will help me to achieve my dream to do the Florence Nightingale course, and maybe one day to become a chief nurse, which is my dream, my hidden dream.
Let's see. We will follow your career with great interest, for sure. Thank you, Anisa. If you want to leave us now, that's absolutely fine. Thank you.
Bye. Thank you, everyone. Bye.
Bye. Lovely. So thank you, everyone, and what a lovely staff story. Just the kind of things we need. Let's sort of get back to sort of the more mundane aspects of our work, and get through our agenda. And the next thing are the minutes of previous meetings. We have two sets of minutes in the pack, as you will see. Our normal board, which was on the 14th of May, and then an extraordinary board meeting on the 30th of June. You've hopefully had a chance to look at those minutes. Can I have board approval? Oh, David?
Very minor point. My comments have been interpreted that I create a link between cancelling patients for operations and complaints. I speculated that there was a link. We don't have evidence there was a link.
Was that in the 14th of May minutes, David?
Yes, the last minutes, yeah.
Oh,
Sorry,
okay.
the June minutes.
The June minute. Okay,
Yeah.
so thank you. If I could ask Stuart and Debbie to reword that would be helpful.
I'll liaise with them. Thanks.
Perfect. Thank you very much. Any other comments or concerns about those two meetings? No. Can I have approval that those are a fair record of those meetings, please? Thank you very much. Let's move on. And then let's move on then to the action log. Stuart.
Thank you. So the updates speak for themselves and hopefully make sense. I would just highlight with regards to the renal services that my discussions with the medical team, because the medical director is not here today, Suresh is deputising for him, that an updated improvement plan will be uploaded to the board papers website subsequent to the board update. Suresh, was there anything you wanted to add to that?
Thanks, Stuart. Just kind of giving a verbal update I thought would be helpful. So I think I'll probably start off by saying that it's been a significant piece of work that has been done over the last 18 months or so. And I think I'm grateful for the support which has been given to the specialty, the division from the exec team and all the other teams who have been involved. So I think just as a summary, there's about 27 actions emerging out of the renal PSII, and I'm pleased to report that pretty much a majority of them have either been completed or well on way to completion. So in terms of the domains of the actions, I think there was 4 domains: water safety, quality and monitoring, there was capacity modeling, there was contract monitoring, and there's risk management. So a couple of those domains sat within the divisions and specialities, and I'm pleased to report that pretty much all of the actions are complete or close to completion. That includes dialysis capacity modeling until 2030. And I think with support from the exec team, we are well on our way to managing dialysis capacity in terms of the infrastructure projects which we will embark in this financial year and the next financial year and beyond. We have done a huge amounts of work focusing on safety for our patients and accommodating dialysis capacity in innovative ways over the last 18 months. And hopefully with the modular unit coming online, we should be able to then proceed to the long-standing ambition of creating a fit-for-purpose home therapies unit. So I think the summary for this board would be that the actions across all 4 domains, significant amount of remedial work and mitigation and improvement have been completed. There are still projects and infrastructure projects that need to be realized over the next 2 years, for which we are continuing to work towards getting the necessary resourcing to make those things happen.
That's very helpful, Suresh. Thank you. Given that was quite a detailed update, are there any questions or comments for Suresh on that update? No, I don't see any hands raised. Thank you, Suresh. Adam.
Not so much a question, but just one point to add, because people will recall this was our first real use of the PSII process, and it was a big investigation. And as part of that, we've got coming up a kind of reflective session to really understand the learning from that process as we get better and better at implementing it. So again, not so much on the specifics of the renal one, but actually just how that worked. And I think that will strengthen our ability to do this kind of investigation going forward.
Brilliant. Thank you for that. Yes, absolutely. Right. Stuart, was there anything else you wanted to draw to our attention from the action log?
Nothing else to draw to attention. The actions are either completed or in train.
Brilliant. Thank you very much. Any comments, questions on any other items on the action log? No. Okay. Thank you very much. Then let's move on to see if there were any public questions. Now, I haven't been notified of any. Stuart, have any come in the last day or two?
No public questions.
Thank you very much. Okay, let's move on then to the next item on the agenda, which is my report, which is a verbal one. There were a couple of things I wanted to draw the board's attention to. As I think most of you know or will have spotted, we're delighted to have Penny St Martin, who has joined us as our Chief People Officer. This is her first board meeting, and we're really looking forward to working with you. So welcome, Penny. I can't say that, however, without saying thank you so much to Amanda Harkus, who has done a fantastic job in the last few months of interim Chief People Officer, has really done really well and held the fort, and I'm sure will have made the Penny's transition that much smoother. So our great thanks from the board to you, Amanda, for everything you've done to help us over these months. I'd also like to, oh no, I don't think Lorraine Williams is not observing today, I think, so I'll leave that. We do have, I think, Dawn Scrayfield observing us, or I was expecting her to be observing. I can't see her, so maybe she hasn't joined it.
So Anita, it was late apologies. She had to attend another meeting, but she will be observing the recording.
Oh, okay, that's fine. Just for other board colleagues, Dawn Scrayfield, who works for Mid and South Essex, as part of her development, had asked that she could observe our board meeting today. So I was expecting her to join us live, but that's great. If she's looking at the recording, that's fine. The other big piece of news that happened this week is regarding the Hertfordshire Medical School. I don't know if Zoe's on today, but there was a real milestone for the University of Hertfordshire this week or last week, where GMC have done their screening check. It went very well. There was some real highlights, and they were commended on several items. And this means that their first cohort of international students will be joining them hopefully in September 2026 next year. A real milestone for the medical school and for the university. Great news for them, and hopefully great news for us, as it will strengthen our partnership with the university, and we can provide a good environment for students to work and learn with us going forward. So congratulations to Zoe as Dean of the Medical School and the university for that achievement. If there's no questions or comments on anything I've said, I'll hand over to Adam for his report. Thank you.
Thank you, Chair. And just to point out, Lorraine Williams is actually sat with Teresa in her office, so she is observing, but she's doing it in close proximity to Teresa during the meeting. My Chief Exec's report is in the pack, and I'm not going to go through it in detail because people will have read the points, but I just want to emphasise one or two specific issues. There's been a theme in recent reports of the significant change that's happening in the NHS infrastructure at the moment. People will be aware of the announcements from government back in March describing the halving in size of NHS England at national level and also in the integrated care boards. In terms of the ICB's response to that, to reduce their costs by 50%, a range of clustering has taken place with proposals to reduce down to 3 ICBs across east of England compared to the 6 were in place. That will see in other areas, Norfolk and Suffolk ICB, a greater Essex ICB that will impact on us in that West Essex will be moving into that ICB. And then the remaining ICBs, i.e. us, Bedford, Luton and Milton Keynes, and Cambridge and Peterborough will be coming together into one cluster. Initially, these each take keep their own legal form, but will be working as one. But it's expected that changes through legislation and others will mean that will formally become one ICB in time. There's significant pace in that piece of work. Including, I think, leadership appointments will be made in a very short space of time, which will then flow through to restructures and appointments made across those organisations. So I think we should acknowledge that on a human level, colleagues in those organisations are going through significant change at the moment. We have offered at various points, I know colleagues will have done the same, support where we can for that process. But also the challenge of maintaining their functions whilst although that work goes on. And we'll touch on that in the Board Assurance Framework risks later on. There have been a number of positive announcements in terms of changes and investments from the government, and one I just drew out here is the model that has been adopted in Hertfordshire on our site to have a mental health urgent care centre is now being deemed as good practice and being rolled out across the country. We've already seen the benefit. Our ED staff have seen the benefit of patients being able to be transitioned into a more suitable and therapeutic environment rather than the busyness of an ED. And the feedback from patients I know to our mental health trust partners has been really positive. We're currently working on extending and improving that service further through the more combined physical and mental health support for patients that might need low-level physical health, and using staff from our urgent treatment centre and seeing how we can outreach into that unit. So that's definitely one to watch this space, but it's great to know that we were at the vanguard of that work really in terms of setting national policy. The other thing I just wanted, or a couple of bits I wanted to flag, the E&H production system. We have very recently tried a new tool as part of this system called 3P, and that is something that is really only applied for big transformational changes rather than more of the daily improvement work. And we were taken through that process a few weeks ago now in paediatrics. People will be aware that part of our plan is to create a better physical environment for our paediatric wards and service. And I think many people went into the week's activity thinking this was a kind of architectural exercise of designing a new ward, but actually very quickly realised this was far more about creating a vision for what paediatrics could look like, of which the physical environment is an element. And I know Lizzie Franklin-Jones, who is our lead nurse in that area, spoke to staff through the Trust newsletter about what a fantastic week it was. And I know, speaking to some of the play therapists when I went over for a visit, actually had their views completely flipped on their head in terms of what to expect. So it's definitely a case of watch this space, but I think it'll lead to some quite exciting times for our paediatric service. And then I mentioned in the people update a number of events we've been celebrating over this period. Pride Month being a whole month event, as the title suggests, but a number of other celebration days. And some people would have seen some of the news around the Healthcare Estates and Facilities Day, where I spent some time in catering. And if anyone would like my lemon, cucumber and poppy seed recipe, I'm very happy to share it with you, because it was served the next day in the restaurant. And as far as I'm aware, nobody ended up being admitted on the back of eating it. So really important for us as an organisation, I think, to celebrate particularly those professions that don't necessarily get the limelight, not just for our staff, but also, I think, importantly for our employment of the local population. There still remains a view in many young people that unless you're a doctor or nurse, well, the NHS isn't for you. And I think there's the people teams that are a lot of work reaching out to local schools, etc., to really try and celebrate some of these other career opportunities. We've had a number of people recognised and attending significant events with members of the royal family and others. But a last couple of bits I want to draw out, because we often describe ourselves as a DGH plus in this organisation, and our primary focus is on providing good quality care to our local community. But we do have some services that we know extend far beyond that. And Mr. Vazdev, who is one of our surgeons using robotics, is speaking at European Society for Robotic Surgery and giving a keynote speech there. And I think that's some real reflection on our robotics programme. But also at Mount Vernon, there are a number of services now. We are the only trust in the country to do across robotics actually as well. But at Mount Vernon, you'll see here an injectable form of immunotherapy. We're the first in the country to do this, and I think it's going to be interesting as we see that roll out, but also we continue to push the boundaries for cancer patients through the Mount Vernon Centre. So that's all I wanted to share at this point. Thank you, Chair.
Thank you, Adam. Any questions or comments for Adam, please? No? Okay, Kevin.
Apologies, my computer is playing up. There were some elements, Adam, we spoke about the use of the trust seal.
No, we don't need to cover that, Kevin. We don't need to cover that.
We don't.
No.
Okay, thank you.
Brilliant. Okay, thank you very much. Then let's move on to the next item, which is our annual Freedom to Speak Up report. Welcome to Sylvia Gomez, our Freedom to Speak Up Guardian. Thank you for joining us yet again. We're always good to hear from you. I'll hand over to you. Thank you.
Thank you very much. I'll take the paper as read. I'm pleased to report that this year we have had a year-on-year increase in our Speak Up cases. The last financial year, we had 311 Speak Up cases in total. Worker safety and well-being involved 47% of the cases, and 35% involved inappropriate attitudes and behavior. There was 12% of the Speak Up cases related to patient safety, and 6% related to bullying and harassment. There are a few key things that I would like to mention. So one of the things that I want to mention is that 70% of the cases that came to me, our staff had spoken up to their line manager or to the appropriate individual, and they only came to me because they perceived there wasn't meaningful action or their voice wasn't heard. So what have we achieved over this last year? So first of all, as I've discussed, there's been a rise in Speak Up cases from our people. But more importantly, what I want to tease out is we have had staff speaking up across all our staff groups and from our diverse workforce. And it represents the whole breadth of grades and seniority and levels. And this, I think, is something that the Trust needs to be proud of, because it very much feels that our workforce, our people are empowered to speak up. The second achievement that we have had that we should be really proud of, there were no anonymous Speak Up cases in the last 12 months. We continue to have a very active Speak Up Champions network, and we recruited a further 8 Speak Up champions, again across all staff groups. There was a reduction in CQC whistleblowing concerns. There were only 2 whistleblowing concerns raised in the last 12 months compared to 23 the previous year and 4 the year before. Our NHS staff survey, so I hold that quite clearly because that gives us a little bit of insight into how effective the Speak Up function is. And there has been, again, a 3% increase, which is classed as significant, in staff having confidence that if they speak up, the Trust will address their concerns. We have had an increase in local resolution and facilitated conversation. Our staff are embracing speaking up training. 88% of staff have completed Speak Up training, and 85% of managers have completed Listen Up training. And the other bit that I thought the Trust Board would like to hear is that we've had positive feedback from staff who have accessed the service. And what they have reported is that they felt supported, they were grateful that their voice was heard, and actually thanked the organization for taking their concerns seriously. And I would like to thank all those managers, the different departments that have actually helped address these concerns. Because as you know, I don't work in isolation. So I ensure that staff voice gets heard. But across all the other departments, they help respond to the staff voice. So I would like to acknowledge the support that has been provided by the organization. So what do I think we need to learn and improve from over the last year? So fear continues to be a barrier to speaking up, and the need for us to develop healthy teams, embed psychological safety within teams continues. But more importantly, if we could embed and establish a just restorative learning culture, it would ensure that staff are speaking up to the appropriate person without the need for the speak up function, without the need to access speak up function. We also feel that we should have more mediators available within the organization, because what this has highlighted is if mediators are easily available, they could support early to de-escalate interpersonal conflict. And the delay in accessing mediation actually increases the risk of prolonging the ongoing interpersonal challenges. We need to support our leaders and managers, to develop and embrace the just restorative culture framework, so that staff feel that their concerns would be taken seriously, and it would be addressed in a fair manner. The other learning that we need to have is recruitment managers now should provide meaningful feedback in following interview. And this should include examples of model answers to all the interview questions, because I think that would ensure that staff needs are addressed and our people don't go away feeling that the interview process was unfair. And they can actually use that feedback to improve, to develop, and it will help them for their next career, towards their next career progression. Incivility continues to, there are pockets of areas within the organization where incivility continues to be a problem. And so the Civility Saves Life work that has started needs to continue, but we also need to grow that a bit further. And this is around how our service users are being kind to our staff, and how that mutual respect can actually ensure that our workforce feels safe to deliver care. And the other area, I think, is there's more maturity required from the workforce to appreciate and manage so that we can manage their expectations when they're raising concerns or when we are responding to concerns. So I'm going to stop there, and I would welcome questions. Thank you.
Thank you very much, Sylvia. Really helpful summary, and it was a very good paper, by the way, so thank you for that. Right, several people, hands have shot up, so let me come to Jill first.
Thank you. Thank you very much, Sylvia. It's really good to see this report. It's such a valuable source of information for us as a board. Really good to see that your recommendation about your reports coming in future to the Quality and Safety Committee. That's something that I've very much sort of championed thus far. And really hoping that as we receive that information, there is a greater degree of triangulation undertaken by Teresa and Justin with the other routine sources of information that we receive, so that we really make use of this and interpret it correctly. And I know Teresa and Justin have had a number of conversations about that, so I look forward to that happening. There's a few comments I would like to make, though, about the report. The first is, I suppose, you are specifically about protected time for the champions, and I have to admit I remain unconvinced about that. Incredibly important role, but as you've taken, you've got 40 such champions, and we have 300 or so issues coming through. I think looking at the numbers, that is something that is achievable. In terms of not carving out additional time, but I may be an outlier on that one, but that's just, I remain unconvinced, I suppose, is what I would say about that. I do think it would be really helpful in any future reports if there's a marvellous analysis, obviously, on the professional sources and the themes, but it would be really good to support the board's view of issues from wards to strategically the boards, if there was an additional level of analysis on specific teams or wards to strengthen our oversight here and the committee's oversight. And also in terms of any annual report, I would just say, as I'm privy to quite a few of these across the country, I think it would be, you know, perhaps a suggestion to have a statement from the executive lead and the NED lead for this in any future annual reports. I think that would enhance it. But I congratulate you. It's a really valuable source of information. Thank you.
Thank you, Jill. Oh, sorry, did you want to come back, Sylvia?
Yes, very quickly. Thank you so much for your comments, and I will take them on board. With regards to the Speak Up champions, one of the key roles of our Speak Up champions is actually to influence the culture within their teams. And there is an element where the ward managers or the managers within the department have within the portfolio the bit around people's voice. And so what I'm asking for is not additional resource in the sense that we get additional money for that, but actually to find a way by which the managers use the Speak Up champions as a vital source to hear the voice from their own teams. And I think that element where you get our staff to, you get a few people to influence the culture within the department will actually help us address issues around incivility to ensure our trust values are lived and people feel the trust values. So those were the bits, but I'm happy to discuss this outside the board also. Thank you.
Yeah, I think that's a helpful clarification, and I have to say, Sylvia, I have come across that model before, where Freedom Speak Up champions are also culture champions, effectively, and were hooked in directly into the ongoing culture at work. So I think that sounds like what you're talking about, and it worked very effectively actually where I've seen it at previous trusts. So certainly something for the team to consider, the executive team to consider. Thank you for that. Richard.
Thanks, Anita, and thanks, Sylvia, for the report. I think it was a really good report, and I think you have made it clear that we're making good progress in this space, which is really important to kind of create the culture we want. It is also one of these things which is really difficult, and I was happy to hear you say that, you know, although it's good to see the amount of concerns increasing, because that says something about people being, you know, able to speak up, the need for this should really be reduced, right? And you said that that's really down to probably leadership to kind of see that change. And I'm really interested going forward in how we follow our ability to deal with these things as part of the line responsibilities of the leadership, rather than seeing an increase of concerns raised through this vehicle. And I know this is a difficult question, but it's really one I'm interested in. I've got a specific question, which is, so if you look at the increase in concerns being raised, there's a significant difference specifically related to the Asian ethnicity. And I was wondering, is there a specific reason behind it? And is there any relation to the employee survey outcomes that we've seen?
Okay, can I answer those questions? Thank you very much. So I think we need to, as an organization, invest in our managers. So the bit we need to consider is our managers or supervisors don't just sit at band 7 and above. So within the admin clerical team, you could have supervisors who are band 4, who are band 5. Where you have leadership training focused on banding, it misses out a large chunk of people. So there's an element where we actually need to coach and help our managers gain people management skills, but that alongside just restorative framework, so that the approach of following due process or following policy is all there, and that would actually enable managers to address concerns and be more receptive to listening to the staff voice. So that is one of the things. The second thing is, you are right about the fact that my report aligns with the fact that Black, Asian, ethnic minority groups have been speaking up more than our other workforce. And I suppose that is a reflection of three things. One is how comfortable our staff feel going to their manager. So that is the thing, it's how safe do they feel going to the manager. The second thing is it's about what they perceive as being treated differently to others. And sometimes, a key factor that I included, giving meaningful interview feedback to applicants who haven't succeeded. Sometimes in order to comfort them or to make it easier, they kind of say, you were nearly there, you lost by a point. But when they get this information repeatedly, interview after interview, they feel that the organization doesn't want to promote people from their ethnicity. But in reality, when I have gone to look at the granular detail, what I have uncovered is they did not do well at interview. And actually giving them that feedback to say, these were the questions that you could have answered better, would help them improve for their next application. And I think these little nuances things would help. I hope I've answered your question.
I think that's a really good point, Sylvia, and it's one that I've reflected on myself, that I think we actually help people more by telling them what they need to improve on and helping them get there than just sort of platitudes. And I think that is I've come across that too. So no, thank you for that comment. Janet.
Thanks, Nita. Yeah, thanks, Sylvia. It's really, really helpful. And obviously, we've had some discussion at the People and Culture Committee as well. I guess one of the things that strikes me is that lots of managers have had training, and yet this continues to be an area where there is an issue and people feel they need to speak up even if they've raised something as a manager. And also looking in more depth at the report, there are lots of different streams of training going on and available to people. And I guess I'm curious as to how effective you think some of that training is in terms of actually moving the dial and really helping these managers to create the, what you describe as that psychological safety and that healthy team. And then the sort of second part of my question is, what sort of a role do you feel the HR business partners should have in that process as well?
So with regards to the training, what we do know is that you receive the training and then you need to practice. And when you practice, you need somebody to support you as you're practicing this. And I think that's where the HR business partners or other senior, managers, buddies, mentors could actually help. So that bit where, you get the theory, you're applying it. And what does that feel like on a day-to-day basis? Because it's very easy to sit in a cold classroom and absorb things and say, actually, that's what we need to do. But it's the challenges are when you are extremely busy, you're under pressure, and you've got to meet the demands that are coming from the staff. And it's just having that little bit of support, that mentorship or coaching, where they can take scenarios and learn from it. I think that would actually help. But you are right, training on its own will not deliver. Thank you.
Thank you, Janet. Thank you, Sylvia. Nina.
Thanks, Sylvia. I thought it was a really good report, and it's really great to see all of the work that you've done from when I first joined 2 years ago. So really well done. And I just wanted to ask, so nursing and midwifery seems to consistently be a little bit higher than everybody else. And is there any themes in particular that you're noticing that are coming out that we could maybe start to tackle more widely?
So my answer is going to be slightly biased, and the reason I'm putting this caveat is people come to me when things go wrong. People don't come to me when things are going right. So what I do not know is how many times actually things have gone right within the organization and I don't know about it, because I come with a very skewed view. So what I have uncovered is you will have excellent bedside nurses, great nursing skills, and then they get promoted, and they get promoted to manage people. And suddenly they're no longer responsible for their own actions, but they're responsible for the actions of others. And that's a hard area to navigate, and it needs more support. So what we really need to start doing is, because we know our band 6s will become board managers, we need to have an emerging leadership program where we actually upskill the band 6s, the band 5s around people management skills, how to communicate. And actually, by the time they become band 7s, they will have a few skills. So what you're seeing a reflection of, where when quite a few, it's slightly more than a slightly increased workforce is coming from nursing and midwives, is where the manager needs support with following due process and understanding the policy. So I hope that helps. But one of the things I do want to point out is, when I joined this organization, we had not had a single member of the medical team speak up. But if you look at the figures now, the medical team is almost catching up with the nursing and midwifery team. And it also represents a larger portion of our workforce. Thank you.
Yeah, thank you. And
Thanks,
it was actually something I noticed as well, that increase in medical. It's great to see. Right. Diana, our freedom to speak up, Ned. I was going to come to you anyway, but over to you.
Yeah, thank you, Anita. I was going to say actually that as the freedom to speak up, Ned, I just wanted to commend Sylvia and the other champions, the freedom to speak up champions, on the great work that they've done. Since joining the board, I've really been impressed by all of the things they have actually managed to achieve. I think I wanted to make one sort of main comment, and it was really about emphasizing the need, I think, to better sort of strategically and practically align the work that the freedom to speak up that we do within the trust, align that with the work that we're doing in the people team. I think that there are lots of overlaps. You can see that, and I think, and Sylvia, you may come back on this with more specifics about the way in which we can practically and strategically align freedom to speak up with the overall work of HR. I do think that there's a lot that can be learnt from the things that Sylvia's pointed out in her report and the work that she's doing overall, particularly in regards to supporting line managers and improving the training, because I think, there's a lot that we can do to improve our training, make changes to our training, and then the support that line managers have following up from the training to actually improve things overall. And I think we need to do a bit more work around that.
Thank you, Diana. Right, Tisha Farah.
Thank you, Chair. So mine is really just a question regarding those people that had concerns and felt that they were not heard. Do we have a standardized response template of some sort that sort of interrogates, when someone puts a complaint, just so that they can see the process and sort of get a sense of belief that actually it didn't just go from me to you and then ended there and then you just give me this paper? Is there some sort of template that shows that after you spoke to me, this then happened and then this then happened and this happened, and then have that as a standardized response across the trust, so that for any, regardless of what department, what complaint, there is that structured response?
Thank you, Tish. I'm not 100% sure whether we have a template or no, but I will take that away and I will make inquiries. I most certainly have a template for what happens when staff speak up, but as to what managers do, I'm not aware. But if anybody on the board present here knows about it, thank you.
Great, thank you, and a good question, Tisha Farah. Thank you. Right, I know Adam wants to come in, but I think I'm going to, if I could go to Penny first, and then I'll leave Adam to have the last question. Penny.
Thank you. It was more of a thanks very much, Sylvia, because that was really helpful. This is my day 3. I know there's work already started on some of this stuff in the resourcing team to address some of the issues that's been raised. But I think, and I put in the chat some of the things which I think that someone just mentioned there, Diana just mentioned about triangulating some of the stuff that we're doing is really helpful. So if I could follow up with you and Amanda and a few others outside, I think there's some real nuggets we can pull out of that paper and then link it into what we're doing from a broader kind of resourcing and ED&I perspective. So it was less of a question, more of a statement that, you know, it would be great to follow up with you, because I think there's some really important points here. So thank you for that. Thank you, Chair.
Thank you. Thank you, Penny. Absolutely. And I think several of us, and in fact, Adam and I only last week were talking about how might we do some of that triangulation of data from multiple sources. So look forward to seeing some progress in that area. Finally, Adam.
Thank you. 3 very brief points. So one is recognising Nina's point about the nursing midwifery, but I think it's 29%. I suspect someone will know the actual number, but nursing midwifery is probably making up more than 29% of our workforce. So actually, in relative terms, I don't think it's jumping out as a particular issue. I think there's a question for us as the board. There is when we talk about this work going to 2 or 3 different committees, I think we need to be mindful of what we're asking the committees to do. So if this predominantly sits with the People Committee, what I don't want is Sylvia coming in presenting the same paper to Audit and Quality and Safety. And we just need to be clear that we don't create a bit of an industry, and it is about what are those themes that sit in the bailiwick of different committees, so they can do their right bit and make that triangulation. I don't know what the answer is, but I think as a board, if we are having the committees do our work, we need to agree where that's sitting. And the third point was one that Sylvia and I have been discussing a bit, and it comes through in here, but also in response to the staff survey. I think there is a very practical thing around this feedback from interviews, because I know a concern, particularly around a perceived discrimination. I think one of the issues that has been drawn out is that because people feel difficult sometimes having a challenging conversation after an interview, it's far easier to say, you did really well, we just had a better candidate on the day. And if you're told that 2 or 3 times, you start to have to understand, because you're never giving any practical reasons. You're told you're great, but you don't get the job, and therefore you're looking for reasons. That when I use the word perceived discrimination, I'm certainly not saying there will never be any, but what I'm saying, we need to make sure that managers are more confident in understanding that a real valuable bit from an interview is giving people practical feedback, even if it's difficult initially to receive, because you can do something about that and understand for your next interview. Thank you.
Yeah, thank you, Adam. I have to say I agree completely with those comments. I think both as regards, let's be really clear which committees need to see what and what the purpose of it is. I think that's absolutely right. And I also think that bit about feedback from interviews is essential. No, totally agree. OK, I think we have no more questions and comments, but the fact you generated, I think it was 7 or 8 I counted there, Sylvia. So that's a positive thing. Obviously a lot of interest in this subject. Now, board, this is a paper for assurance, and it has been assigned an assurance level of reasonable. Are we comfortable with that level? The 1 up would be substantial, 1 down would be partial. It's in a reasonable. Are we comfortable? Do we want to change it? Can I have a show of hands for retaining reasonable, staying at reasonable? Do we have interest in that? Yes. How many people? Oh, Jill, you want to come in? Oh no, you were just voting. That's fine. That's fine. Okay, it's slightly trickier here to see what people want to do. So I think, Adam, there's about 4 people with hands up, and I had various people showing physically showing hands up. So I think we're saying that was probably about half people. Okay, let's do it the other way. Can you raise your hand if you are not in favour of and actually let's do raise hand if you're not in favour of reasonable, and then we can find out what it is you do want. I don't see any hands for changing. So I will assume that means, I apologise that this is a little bit clunky in Teams, but we'll get there. I'll sort out how to do this. But anyway, okay, I think we have a board decision to retain an assurance level of reasonable. Thank you, Sylvia. I think it was a good paper. I think it would be good to have a comment, as I think Ms. Jill suggested, having a comment from Diana and from, well, it would be Penny going forward. I think that would be helpful additions. But I think it was a very good, thorough paper. Thank you very much for your time today. Right, thank you. Let's move on then to our next paper, which is the Green Plan refresh. So that's Kevin, I think.
It is, Chair. Thank you very much. I have the pleasure of the introduction, and I'm going to hand over to Helen, who's the author of this. And of course, Justin, if he was here, would have been talking as the chair of the Sustainability Board. I think that also starts off by saying how much it is actually not just, and I made the statement yesterday, sustainability is not just about the boiler house. And I'm extremely proud of the paper that's here. I'm sure there will be a number of questions. It's very dear to a number of people's hearts. But you've got to remember the Sustainability Board, who have created this under the tutorage of Helen. 95% of these people don't have anything to do with sustainability in their job descriptions, but they give up their time and work on this extremely hard. We had the Green Plan brought to us in January 22. We had a 21 to 24 plan, which was adopted by the board, which was brilliant. And there has been a huge amount of work with Helen, which we'll go into in a minute. A lot of it is around things like lights and solar panels and everything else, which are popping up all over the place and are brilliant ideas. But there's a huge amount behind that I think needs applause, and we need to start blowing our own trumpet on this. We are substantially further on than other trusts, I personally know, and I'm very pleased with it. But this is a refresh brought about by the government guidance that was released in February 2025. It has been reviewed. It has been has had external review by experts as well, and it has been submitted in time. So again, we're in with our sustainability plan. So I really and truly, I don't want to go any further, because I think the people who did all the work and the supporting people like Karen, who has been there from day one, will probably be able to fill in more. So if I could hand over to Helen, I'd be very grateful.
Thank you, Kevin. You stole some of my narrative, but that's okay. I'll forgive you. So the Trust Green Plan. So we received the guidance in February 2025 with the deadline of July 31 to review and reflect our current Green Plan and see where we're going to be strategically for the next 3 years. So as Kevin's already mentioned, I'm happy to say we've achieved this deadline. Not a lot of other trusts have, and I've had to extend their deadline to October. So a pat on the back to everyone that was involved. So as part of the review, so what we did was hold 2 workshops with both clinical and non-clinical colleagues from across the trust. Our workshops were attended and supported by a regional net zero lead and also Carbon Architecture, who are our energy consultants who support us on a number of projects across the site. We took an honest and pragmatic review of what we had achieved, including a reflection of the barriers and challenges, of which there were numerous. But since the launch of the Green Plan in June 2022, upon reflection, I think Kevin's already touched upon, we feel like we've done okay, from raising the awareness around the sustainability agenda to talking about what the net zero targets are, to being awarded over £4 million worth of funding, and that money has been spent on the rollout of LED lighting across the trust, and also in the process of installing solar panels on a few of the roofs, which I know you can't see from ground zero, but at the back of the car park is our next big project, and we're rolling out solar panels across there in the next few months. So the next version of our Green Plan, the next 3-year extension, includes the NHS priorities, roadmaps and key milestones, which is embedded within the document. We are going to ensure we take an evidence-based approach like we have last time. And as Kevin's also mentioned, we need to get better at sharing our successes. So one of the key milestones and key actions we're going to include is making sure we do monthly comms, which we haven't been so good at previously, but we plan to do that going forward because there's so much good stuff going on that we really aren't talking about. So the plan that you have hopefully had a chance to look over is very high level. The actual devil in the detail and more meat on the bones will be discussed by the individual work streams. So they will have comprehensive action plans and associated KPIs with those. So they'll be developed starting from September when those additional work streams are up and running. There's kind of 3 work streams in total. So the 2 internal work streams focus on 8 sort of focus areas, which again, I won't go through it, but that's included in the paper. And they're focusing on both clinical and non-clinical actions, which we've been asked to include. There's a 3rd work stream, but that kind of sits external. So that's focusing on procurement, supply chain and adaptation. And that's going to be led by the ICS or whatever form the ICS will be in the next few months or so. I think to point at this stage, the biggest risk to achieving net zero target by 2040, and that's the emissions that we control, is the current financial climate. Lack of funding and resources will compromise our ability to be proactive on the sustainability agenda. Since the refresh guidance released in February 25, there's been a number of major changes really regarding the removal of the NHSE, and obviously we get a lot of support from NHS England, and also the restructuring of the ICBs, again another support vehicle for us. But in addition to that, 2 significant funding streams have been pulled. So the Low Carbon Skills Fund 2025-26 has been pulled, and also the SALIX Public Sector Decarbonisation Scheme, which people know as PSDS 25-26, has also been pulled. Now, we were planning to submit applications for both of those pockets of funding, which is a shame. So a big part of our work is around decarbonising the physical estate, the physical environment, and we were hoping to chip into that. However, on a positive spin, we will continue to look to any other funding pots, because I'm sure hopefully at some stage money will pop up other areas, but we'll make sure we've got our fingers on the pulse, and we will continue to work up business cases and ideas that we have, so when those pockets of fundings do come up, we can quickly react. And that's probably
brilliant,
it for
Helen.
me.
Yeah, thank you, Helen. I just wanted to leave a couple of minutes for questions or comments.
Sorry.
I don't know, given that Justin isn't here, Karen, I don't know if you wanted to add anything quickly.
Yeah, just really quickly, is to say that, as we said at the beginning, this does cover all areas of the trust and all staff are actively engaged in it. And we do want to improve our comms to make sure that we improve that. There is also something about making sure that we embed SIAs or sustainability impact assessments in all of our projects and work that we do. There's an awful lot of things that we do as part of our change program, which actually do lead to carbon reduction. So whether that's having our patient consultations over video links, it saves all of the travel in and out of the hospital. There's so many different ways when we make changes where we actually impact. So it was really to say it's a constructive programme. We will have KPIs, you'd expect me to say that, and the monitoring will go through FPPC, but there's been an awful lot of hard work that goes into that, and there's so much enthusiasm around the trust, which is really welcome.
Brilliant. Thank you, Karen. Hand from Richard.
Yeah, I was just going to say that we have discussed it in FPPC the last meeting, and I think Helen is a little bit modest about the achievements over the last couple of years. So I think we've done some great stuff. Always want to do more, but I think the team has done really great work on this. We discussed, let's say, the plan update. We recommended for approval. There were 2 follow-up actions that we agreed. One is around communication. As I wrote in the chat, sustainability is everybody's business. I think there can still be more done to make sure that everybody feels it is everybody's business. And the other one was around the remark that Karen just made related to KPIs and reporting. But other than that, we really recommend this for approval and commend the work.
Brilliant. Thank you very much, Richard. Adam.
It's not something I expect people to answer now because I doubt the thinking's been done. I guess one concern for me around the approach is that you can't have a conversation now without every other sentence somebody talking about an AI solution. And we know that AI currently, I think, uses about 10% more energy than our traditional digital. And I guess it's something that Mark will jointly lead on with those on sustainability. But I can see a real risk that even on our personal lives, we know that when you're using your phone now, your emails start to get summarized by AI. And I think it's some of those hidden things that goes back to Kevin's point. It's not all about the boiler house or the LEDs, as important as they are. But I think inadvertently we run the risk of potentially driving some stuff like that, which may be a tide that we just can't go against, but it's something I think we need to be mindful of.
Yeah, absolutely. I agree on that point as well. Right, I don't see any other hands. So this paper, is for our approval. As Richard has said, it has already gone through Trust Sustainability Board. It's also gone through FPPC. Are we comfortable as a board to approve this plan refresh? I can see nods. I'll take that as agreement. Thank you very much, Kevin. Thank you, Helen, for your time today.
Thank you.
Brilliant. Let's move on then to summary learning from deaths, and that's Suresh. Over to you.
Thank you, Chair. So just before kind of going into this, I can just confirm that the paper has gone to through the Mortality Surveillance Committee and the Quality and Safety Committee, and the paper is for assurance. So just before I go into detail, just some headline figures. I think learning from deaths, I think the process has been carried on in this trust for coming up to more than 5 years now, or even longer. And the current form looks at the structured judgment reviews and looking at learning from those structured judgment reviews triangulated with various other patient safety and other Mortality Surveillance Committee reports to get a triangulated picture about what the learning has been or has to be. So our trust is in a very good position in terms of the HSMR, crude mortality rate, and SHMI. So the crude mortality rate is 0.88%. The HSMR is 84, which is actually an improvement. The SHMI has also improved over the last 12 months from around 92 to 90.15. The structured judgment reviews, we again are in a very good position in terms of the percentage of the deaths that have gone through a structured judgment review process. So that has gone from 18% in Q3 24-25 to 21%, which is actually what the Better Tomorrow standard is. And just from the initial data, the last couple of months, the numbers have gone up to 25%, which kind of gives assurance that the process as such works pretty well in terms of what it's intended to do. In addition to that, the medical examiner reviews and the activity within the medical examiner's office has actually increased quite significantly, which in a way is a bit of a risk in terms of the number of community that's also come through the medical examiner's office for scrutiny and reporting and assurance. From a learning perspective, I think the headline figures from a structured judgment review process is that in Q4, we have reviewed almost 1/4 of the 387 deaths. And of those that have been reviewed, it is reassuring to note that there's 2 of those patient care episodes that have been deemed as 50-50 in terms of the quality of healthcare delivered being on the poorer side than otherwise. So that kind of equates to roughly about 0.02% of the number of deaths that have happened. There's another 2 structured judgment reviews that have highlighted care quality deficiencies, which has gone through the patient safety teams to look at and learn and understand the learning beyond that. In terms of further learning from the whole process as such, we have identified probably about 5 areas, which I'll probably briefly go into. So one of them is mortality alerts. We probably as a trust have been incredibly good in terms of not having a team of mortality alerts. The current mortality alert we have is for a cardiology, pulmonary hypertension condition, which I think it's currently being looked into in aspects of coding as well as in terms of the case presentation. So that's one of the things that's currently going through review. The second thing is related to the learning from the ovarian cancer management pathways and the systemic anti-cancer chemotherapy related care shortcomings that has been gone through various patient safety incident reporting frameworks, and I think there is some learning to be done through that framework, which is well on its way. There is a third aspect related to sepsis 6 compliance, which has improved from quarter on quarter, but there are certain pockets where we still have areas that need to be improved, particularly relating to the timing of the first antibiotic administration, particularly on the inpatient areas. And there is the fourth aspect, which is looking at the NELA pathway and looking at NELA data acquisition, NELA standing for non-elective laparotomy audit, and reporting. This is a national requirement to report, and there is some risk in terms of our resourcing availability to do the reporting appropriately. So that is one of the things which is currently going to the divisions to try and understand what resourcing that needs to be put in place and whether that can be co-opted into the ICNARC work, which the intensive care team reports. So that is something which is in action which is in train at the moment. So in kind of summarizing the learning from DETS project as such, I think there's a reasonable level of assurance that the processes that have been in place, may it be the structured judgment review, the medical examiner workflow, the patient safety committee work, the triangulation that is done through the mortality surveillance committee, the M&M meetings that form part of the clinical governance monthly meetings. I think there is quite a bit of assurance in terms of understanding of the themes, particularly at the divisional and the specialty level. We remain very well placed in terms of the HSMR and SHIMI compared to our model hospital peers. We are 2nd out of 10 in terms of HSMR for our model hospital peers, which is about 10 to 12 trusts. There is some risks related to the items I've mentioned above, which is related to mortality alerts and sepsis 6 compliance, which we are currently looking into. So I think those kind of summarizes a thematic review of the learning from DETS process that has been tabled for this board.
Oh, so sorry, I was on mute. Thank you, Suresh. There's some hands up. So Jill.
You're on mute, Jill.
Jill?
I think she's frozen.
Oh, sorry, you're on mute, Jill. Can you? No, we can't hear you. Jill, let's see if we can sort you out a minute, or maybe put it in the chat. Let me move on to Karen. But yes, if you could write something in chat, and hopefully we can sort you out in a few minutes. Karen.
It was just a quick question, please, about the medical examiners. You raise a risk, and particularly over the winter, in terms of our mortuary capacity if we don't have enough medical examiners. I was just wondering what type of work is going into just making sure we can address and mitigate any risk there may be there. Thank you.
Thanks, Karen. I think the medical examiner role became statutory in September 2024, and I think the resourcing that we initially put in didn't quite take into consideration the workload which has come from the community, which is a reason why the workload under the medical examiner's office has increased significantly. So currently, between the medical director's office and the medical examiners, we're looking at resourcing in terms of getting training for more consultant colleagues to do some of the roles relating to the medical examiner's office, which is what we're trying to achieve at this point in time. So we've already had a medical examiner role added into, like one of the colleagues taking on the role. So I think there is some more to be done in terms of getting more resourcing into the office that currently there's been quite a lot of offline discussions around that.
So can I just ask, because we have done some additional work in terms of the capacity of the mortuary, are we saying that we are content at the moment that we do have sufficient capacity at the mortuary for winter, provided we address this risk? I think that was the other part of my question.
Could I answer that?
Thanks, Kevin.
So we enhanced the capacity, and we have overflow facilities, and we also have mutual agreements with some of our funeral directors outside. I know that because I was involved in the capacity changes. We haven't come close to our capacity in last winter, but it wasn't the coldest. But yes, we have got capacity in 2 other areas.
Did that answer your question, Karen, or do you want to come back?
No, it has. Thank you very much.
Thank you. Jill, let's try you again. Can you speak now?
I can try again now. Can you hear me? No.
I can hear you very, very faintly, but I can't hear you properly. Can others hear you? It may just be me, but...
Yes, I can hear Jill.
Oh, Jill, go ahead then. I can't, but never mind.
Oh, okay. I thought it was my technical inabilities
again. Now
again.
I can hear you.
Oh. Sorry. Okay, I'm sorry. No, it was just a comment to say, as somebody on the Quality and Safety Committee that has received and takes great significance from this source of information, which assures us that there's considerable expertise in the organisation and considerable commitment internally to learning from deaths. The point I wanted to make was we have asked before for there to be a greater degree of triangulation, and Suresh mentions that, and I just wanted to reiterate that I think starting to see the effect of that within this report that really helps us add value to our interpretation, because we move from just comparing us to others to focusing more on what things do we do internally that really have a knock-on effect to other things. So it's really wonderful to see that start to happen.
Thanks, Jill.
Thank you. Right, next is Richard.
Yes, thanks, Anita, and thanks, Suresh. I had exactly the same question as Karen, so I'll leave that. My suggestion would actually be based on the report, based on the discussion in QSC, that for me, this is a good example of maybe not having reasonable assurance, but substantial assurance in this. So I just wanted to bring it up. Maybe we can look at this at the end of the discussion, Anita.
Thank you very much. You've trailed the comment, so I'll come to that at the end of our discussion. David.
Exactly the same comment. I often attend the board anyway, the surveillance group that looks at this. I think we have, as Jill said, lots of skill, lots of experience, lots of interrogation. I mean, I think the message for the patient and the public here is we really do put a huge amount of effort into assessing whether we've done the right thing, and if we haven't, owning up on it. And this is the evidence. So I would definitely go for substantial.
Thank you very much, David. Okay, I don't have any other hands, so we do come to the question about the assurance level. As you know, the paper was presented with a suggested level of reasonable, but I've had 2 members of the board, including the chair of QSC, suggesting that should be raised to substantial. So maybe that's the best way. Can I please have a show of hands to increase to substantial? 5, 6, 9, 10, 11. I've got a majority there. Okay, 13, 15. I've definitely got a majority there. Okay, 15, right. Can you take your hands down? Would you raise your hand if you object to that idea? Anyone object to the idea of raising it to substantial? I know Tichafara has sent me a poll, but I'll do that for next time. I'm not going to do that right now. Okay, I see no objections. I will therefore take it that our board decision is to increase the assurance level to substantial on this paper. Thank you very much, Suresh. A good paper. Thank you for presenting it so well. Brilliant. Right. I think rather than going on to the next item, I'm going to propose a 10-minute bio break. So if we could be back, please, at 11:10, and we'll pick up the agenda then. Back at 11:10. Thank you. Welcome back to this board meeting, and I will go to item 12 on the agenda, which is the board assurance framework, and I'll hand over to Stuart. Thank you. Stuart, can you hear me? Hello, can anyone hear me? Yes,
can
okay,
hear
you
you.
can hear me. So it's Stuart that can't hear me. Okay, he's gone. He's gone. Okay, he may be rejoining. Hold on a second. I suddenly had a panic that I was just talking to the void, as it were. As Mark says, there are a few funny things happening with Teams today. Not quite as reliable as it normally is. Let's wait for Stuart to rejoin us.
Hi there, I'm back, and apologies for that.
That's fine, no problem. It happens. I can't see. Oh, yes, I can see you again. Stuart, Board Assurance Framework, item 12, over to you. Thank you.
Thank you, Chair. So I'll take the paper as read, and before turning to the spotlighted BAF risk leads to update on their individual risks, if I can just highlight that this is the first presentation of the worked up 25-26 BAF risks. In terms of the assurance recommendation rationale, it may help to just explain that for the BAF process, Audit Committee considered that yesterday and supported a reasonable assurance rating. However, I'm focusing for board on the risk mitigation element rather than the BAF process, and hence why it's a proposed partial rating, because we've got 5 new risks and therefore we haven't had time to actually properly mitigate those yet. An interesting observation for the board is that despite the financial challenges, the 3 quality risks remain the same as last year. However, the 3 thriving people risks have all changed. So if I could turn to the Chief Executive for the first spotlighted risk, if that's okay.
Thank you, Stuart. Yes, the highlighted risk is around system, and as board members will be aware, we shifted the risk really from something around inertia and moving a system that is well established and moving it into a different space through to really instability. And I've already mentioned earlier on in the meeting about the significant changes happening at ICB level and national level, and the changes that's generating, meaning we're in a time of rapid change with various initiatives being announced with a short turnaround time. But alongside that, the work we've been doing at Place, and having, as I updated the board in the last meeting on, having been asked to now take on the responsibility as host provider for Eastern North Herts Place, there's a lot of work going in to set that up in its initial stages, and then through to later on in this year, really looking at delegating some of the responsibilities currently sitting with the ICB down to us on behalf of our local system. Now, this work comes with a load of hours and resources required, and so I know the Finance and Performance Committee raised this. We had a similar conversation in Audit and Risk Committee, and I'd already been updating the BAF anyway, because I think we need to recognise that at the moment a number of our staff are being drawn into work on this, which is taking them away from their day job in light of the context we're in around the financial challenge, and not wanting to bring in more resource. It's meaning particularly senior leaders are stretched at the moment in terms of that work. But alongside that, we've also got the fact that as part of the reorganisation of ICBs, resource will be moving down to providers to take on some of these responsibilities. But we're in that transition stage at the moment where that hasn't been agreed. So we're not able to spend the money or aware of what resources we have. And so there is a real risk in this transition of not wanting to commit to new infrastructure at a time when we don't know what's going to be funded. So what's been updated in this is recognising there are some controls in place. There is a place-based delivery unit that currently sits under the HCT, but works exclusively for the partnership. And so there is an ability to leverage that team in doing some of this work. We also had a change around an exec portfolio a little while ago in anticipation. So Kevin, as our Chief Kaizen Officer, has some time dedicated in his job plan, as it were, to work on system, particularly on the transformation aspects rather than the governance and what we've been doing in setting up. And I've also highlighted at the moment there is this gap in our controls because we haven't yet been given the allocation of what we believe will be coming. And until that is closed, it's difficult to see how we will significantly be able to manage this risk downwards, because at the moment it is the risk in part presents in that individuals, Stuart being a good example as he's in the room, has been spending time on, as we know at our last extraordinary board meeting where we had to agree terms of reference, etc. That would have not been in Stuart's plan for the year. And therefore we're having to look at the compromises at the moment. So I think that probably gives a flavour of the conversations that have taken place and why this BAF risk has moved on slightly. I didn't feel it was significant enough to change from the current rating, but we will keep that under review. And if this starts to impact us over this next period and some of these other expected announcements of resource, etc., don't come to fruition, or we decide that the resource being allocated to this is not sufficient, then we'll keep that rating under review.
Thank you, Adam. Any questions or comments for Adam on that BAF risk and the current rating? Janet.
Thank you, Adam. That's really helpful. And I guess the sort of financial resource is one thing, and then the people resources, as we've discussed, is also another. So I guess it's just making sure that we're cited on that as well. So when resource does come through, we've got that capacity in terms of the people, because clearly lots, as you described, lots of people are being stretched, and it's how do we sort of offer opportunity for people to backfill effectively.
Yeah, just in response to that, I'll say one of the elements we need to consider as part of the halving of the ICB, the expectation is that the resource we get for working at place will only be half of what was currently funded, and there will be people in that process at risk. And so I think there's an expectation that some of those actual people will move into the organisation as well, which will bring new people in. But as with all these things, if we're asking for different roles, there's a challenge about making sure we've got people who are the right fit for the right responsibilities.
Thanks.
Thank you. Then if there aren't any other questions on the first spotlight risk, if I could turn to our Q, Lucy Davis, on the flow and performance risk.
Thanks very much. No change to the risk score, although people will note when we come to the IPR there are some improving metrics here, but I think not yet sufficiently embedded to merit a change to the score. The main new control is our accountability framework that the board has seen recently, and the implementation of that. Also an RTT delivery and validation plan that key people have been working on, which will come to the next FPPC for review, given both the importance of RTT from a patient access perspective, but also its impact on our financial position this year specifically. Other than that, the updates that you see in the paper are tidying types of updates. So happy to take any questions.
Thank you, Lucy. Any questions or comments for Lucy on this particular BAF risk? Richard.
Not so much on the risk, but really to mention the accountability framework again, which I think is a great step forward. One of the best documents I've seen in the NHS regarding this particular topic, and that we are tracking the implementation progress of that in FPPC.
Great, thank you. And yes, completely agree. I think it is an excellent document. Thank you, Stuart, for that, the spotlight. Does anybody, in terms of the other risks that we haven't talked about specifically, are there any that anyone would like to draw to colleagues' attention? Are we happy with the BAF as it is today? Teresa.
Yeah, Just to say, Chair, and assure the board that the risk that relates to special schools, we are continuously working on that with colleagues in the ICB and other sectors. So we're not ignoring it. We're listening to the special schools team, working with colleagues and just trying to make sure we've got a solution on a month-by-month basis.
Brilliant. Thank you, Teresa. Okay, if we don't have any other questions or comments, this paper is for assurance. It has been provisionally assigned partial assurance. The argument for that, I think Stuart said, or he certainly said in the introduction to the paper, is that given that we've been putting some new ones on here, it's sort of implied that we're not fully there, but happy to open it up for thoughts on that assurance level. Adam.
Sorry, Chair, it's not on that, but I just think one thing that I've realised probably worth mentioning, particularly linked to Lucy's item there, with the yesterday's announcement that the BMA resident doctors vote has supported industrial action, which if negotiations with the government don't resolve that, are likely to have an impact. And so I think this BAF risk, the one Lucy particularly highlighted, it just, I'm not suggesting it would at this stage be changing the risk, but I do think there's another complexity we may have to manage, and we've demonstrated as an organisation our ability to do that, but it doesn't come without impact.
Yeah, I completely agree, and thank you for flagging that, which I'm sure we've all seen. Right, so in terms of this paper, going back to the BAFs as they currently are stated, the paper suggests that we have a partial assurance on this BAF. Can I ask for a show of hands for anyone who disagrees with partial? The higher than that would be reasonable, the lower than that would be minimal. We're at partial. Does anyone disagree with partial or want to propose another assurance rating? I don't see a show of hands, so I will take that as board agreement to partial assurance rating for this area. Thank you very much. Thank you, Stuart, for your work on this. Moving on then to integrated performance report, and that's Lucy, I think, this month.
Yes, thanks very much, Chair. And I will try to draw together the 4 quadrants of the integrated performance report. So kind of in one sentence overall, I think we're seeing a gently improving quality and operational performance with ongoing financial challenges and people challenges. And to draw that together in a bit more detail, month 2 saw improvements from a quality and safety viewpoint, particularly in C. diff, where there was an exceptionally low rate of C. diff infection in May of only 2, which brings the year-to-date performance to 20% below the ceiling for the year, which is 82 infections per year as an absolute maximum. And VTE assessment completion does continue to improve. Mortality remains satisfactory, with one outlier being fully investigated, and as the board knows, all deaths are fully reviewed through the mortality and morbidity process. However, complaints have increased over the last 6 months or so, and the themes are fairly consistent, both in terms of long waits for care, particularly in trauma orthopedics, and experience of care in various of our services, perhaps particularly in ED, where again long waits can affect patients' experience of their care, as well as the quality of their care. And that brings us on to operational performance, where you can see the link between patients complaining about their long wait for care and the fact that T&O is the specialty which for a long time has been the most challenged in terms of waiting times, and holds the majority of our ever decreasing but still number of patients waiting over a year. And in terms of pre-COVID, that for patients really is a very, remains a poor experience. Our urgent and emergency care performance was stable in month 2 and in fact has improved in month 3. And that marks now 4 months of sustained improved performance over 73%, not just over 70%. And that has moved us up our regional rankings. It's certainly in June to 3rd in the region, where we had used to have a place around the middle of that table. Our 12-hour performance is also improving, but more recently, and needs more work to embed, and both need more work to push further with that improvement, given the impact it has on patient safety and outcomes. In the people quadrant, bank and agency utilisation continues to reduce, but sickness increased in May, and that will, as well as be difficult for those staff involved, impacts on our ability to meet our activity targets. And indeed, sickness and absence was one of the reasons for small deterioration in our diagnostic weights in month 2 and elective activity. And elective activity levels remain a concern flagged in the finance quadrant, because although we this year we have an elective block arrangement, it's entirely contingent on the achievement of 3 RTT performance targets in March of next year. We're slightly ahead of target on 2 of those 3 RTT targets, slightly below on the 52 weeks target at month 2, with time to improve it, but clearly is an area of concern and lots of focus, including a validation and RTT delivery plan, which we've discussed twice at Trust Management Group and will be coming to FPPC in our next meeting in June. Our financial performance is on plan year to date, but with a known and looming challenge both about delivery of our agreed cost improvement plans and also a remaining unmet target in terms of the total volume of SIPs needing to be delivered this year, being led by Sarah James as our delivery director. Lots of effort going into it, but the gap is not yet closed yet. And new emerging run rate hotspots, which will be focused on in our normal meetings of CSW spend and medical locum spend in the unplanned care division, with face-to-face meetings being organised to address. Very happy to take questions on the operational performance part, and I'll be grateful if the responsible directors answer questions of detail on their parts of the IPR.
Right, thank you, Lucy. What I'll do before I come to questions actually is I'd like the chairs of the committees to of the respective committees to comment, and that so if we take each section at a time and then get the committee chair to comment, and then I'll open it up for questions on that section and we'll work through that way. So in terms of quality, David, as chair of QSC, did you have anything to add to Lucy's comments?
No, I don't. I think my comments are in the summary at my later report, and I think that report shows that we addressed the things we were worried about. So I have nothing to add. Thank you.
Okay, thank you. So on quality, questions. Janet, is your hand about quality or is it about another section?
Just to be awkward, it's actually about a sort of triangulation question.
Oh, perfect. Really. Even better. Even better.
So do you want me to go ahead?
Please go ahead.
Yeah, so what's interesting, of course, is that we've got a reduction in bank and agency spend, but we've got an increase in sickness. And then the impact of that is then we've got an issue around elective care. So I guess it's just, has anyone done that modelling to see if we're actually sort of, doing ourselves a disservice because we're pushing down on one target, and the reality is actually with a little bit of tweaking we get financial benefit and we get improved patient flow. So it's just really understanding how those interplay together. That was my question, really.
A very good question. Who'd like to take that one? Lucy, are you coming in on that?
Shall I start with that one?
Yeah.
Sickness absence is only one reason, and probably not, in fact, the predominant reason for elective activity as a whole, particularly surgical activity being down. But it does play in, and some of the vacancy freeze also is impacting on our ability to be quite as effective with booking as we were before, but being closely managed. So I have deliberately tried to draw together the impact of one on the other. You're right. It's not it's all multifactorial, and I think we do need to keep a weather eye on both clearly sickness and our utilisation of bank and agency, but mostly that is down because we are replacing with substantively appointed staff members as opposed to just leaving gaps vacant.
Okay. Martin, did you want to come in on that point?
Yeah, I just emphasise a couple of points really. I think as Lucy's just indicated there, that the rate at which our substantive workforce is growing is in excess of the reduction in temporary bank or agency staff that we're seeing, which potentially creates a little bit of a kind of financial challenge kind of for us, but that's the dynamic in play. I think from the work that we're doing around kind of elective activity and activity delivery, I don't think that sickness absence has been routinely kind of escalated as an issue that might explain that. Although I'm sure there will be an occasional hotspot.
Thank you. Okay, Richard.
Yeah, mine is a different point, but related to quality and safety. We discussed stroke performance, which was a little bit concerning when we looked at the report even in June. But I think it's good to note that the actual rating mechanism has changed there, and that we are going to spend a little bit more time on stroke in QSC in one of the next meetings.
Okay, thank you, Richard. Adam. Sorry, David. Did you want to come in on that point, David?
Yes. Yes, it is disappointing to see the which looks very dramatic. However,
is it? And David, you're freezing for me. Is that happening for everybody?
Last week, and I gather,
David,
I gather
can I ask you to David, can I ask you to stop and start again, because you froze a couple of times in that, so I didn't actually hear what you were saying.
Okay, right, sorry. Yes, it's disappointing to see that stroke performance has deteriorated, and on the face of it, it looks significant because our SNAP report has dropped from B to E, I think. Lucy's suggesting that I've got that wrong. However, the criteria have changed. I've just come back from the Stroke Association board meeting, and I was told by the director of the SNAP report that the vast majority of trusts have dropped in a similar way, simply because of the annual criteria change.
Okay, thank you, David. Lucy, did you just want to come in and clarify on that point?
Yes, you're right, David, that the stat rating has deteriorated in the way that you said, but it is entirely to do with the metric changes, as you've outlined, has happened to the vast majority of trusts, and we will bring a more detailed report to QSC, but actually our performance is stable. Lots still to do on it, but please do not interpret the change in rating as a deterioration in performance. It does not reflect that.
Okay, thank you, Lucy. Adam, you wanted to come in.
Yeah, I just wanted to take a point back to the sickness, just to remind ourselves that actually when you look at the data, although has been highlighted, May was up a bit on April, it still remains well within normal variation, and actually is bang on the median point over the last 2 years. So I think that's it's a 1 point data issue. And actually what's probably more encouraging is if you look at the turnover rate, we've actually seen a consistent fall now since June 23, which is when the graph starts. It may have even been further than that, which is really encouraging how we're seeing that turnover improve.
Okay, thank you for that. Okay, if there's no other comments on quality, can we turn to operations and finance? And I'll turn to Richard, whether there's anything he wanted to add to Lucy's comments on those two areas.
Are you going to still have the board report as a separate item?
Yes, we will have the board report. So it's just specifically on the IPR I was talking about.
Then I'm going to leave that for the board report.
Okay, that's absolutely fine. Any questions from anyone on either the operations or the finance? Jill.
Could I just ask, with regard to the CIP position, would it be helpful to have a common understanding of what the level of performance would be, say, for example, at month 6, that would warrant some conversations about seeking additional support? Is that something the FPPC is considering, or?
Martin?
Yeah, it's a good question, Jill. I mean, the FPPC already receives if you like, an in-month kind of report in terms of kind of progress as we go along, and we'll receive that at the end of July in terms of the position at the end of kind of quarter 1. The delivery board, which is the management kind of group that kind of oversees the programme, will kind of receive at the end of July a forecast outturn position, and obviously SIP delivery will be a key component sort of that. I think that will then very much kind of frame a management view and then feedback both to board and FPPC as appropriate in terms of the delivery kind of forecast and any changed or escalated steps that might need to be taken in response to what that outturn might look like.
Thank you, Martin. Adam, are you coming in on this point?
Yeah, well, no, not on this point, actually, on a new point.
Okay.
But if there's no more hands, I'll jump in on the new one. Just really, so Richard raised the point earlier on about the accountability framework and what a good document it is, and the document's fine, but it only comes into fruition when the rubber hits the road. So recognising what Lucy and Martin have described already about one or two of the hot spots that have emerged, it'd be just good to know how that's now being applied and what kind of escalation. Lucy kind of touched on it briefly, but what kind of escalation is now taking place because of those hot spots, or is it not at that stage yet?
Martin?
Yeah, so look, we will be bringing a report back to again July's FPPC in terms of kind of the rollout of the accountability kind of framework. I think probably back at our seminar in kind of May thing, I think kind of Jill kind of really sagely kind of advised us this would probably take longer than we originally had in the timetable. I think that's right. It is going to be a bit of a beast to kind of roll out, but similarly an important journey to kind of go on. However, even as we begin to deploy, I think we're already into a phase where we're kind of using some of the principles of that enhanced accountability framework into escalated conversation. So a good example of that at the moment is an escalated finance conversation that will be happening with the unplanned care division towards the back end of kind of July as a product of a variance from plan across month 2 and month 3. Already this year, so some aspect of reset that we need to talk about with that division. So myself and Lucy have agreed a process that will go through kind of with that very much embodies the principles of the enhanced accountability kind of framework. So we are, although some of the technicalities of it and some of the data presentations may take still some weeks and months to kind of come together, although we're working hard on that, we're already beginning to, as I say, deploy the principles of it into our business activity.
Thank you, Martin. Any other comments on operations or finance? I actually had a question on the operations side, and I'll pose this to Lucy. So it's really good to see the progress on the 4-hour target. I do always, however, have a slight anxiety, because if we push too hard on one metric, there's a danger that we get the flip side on, say, the 12-hour, because actually it drives behaviours that mean that we focus on one target at the expense of another. I noticed the 12-hour isn't doing as well as a 4-hour. How confident do you and the team feel that isn't happening, and that that the metrics aren't driving potentially unhelpful behaviours on occasions?
Yeah, I think one of the reasons it's taken us, and the us is a very big us, as long as it has to get to this level of performance in UEC, by which I mean on a number of metrics, is because we're doing it properly and not, not taking actions that aren't really justified, or that are predominantly about, meeting a performance target rather than actually improving flow and experience for patients. The 12-hour is a harder target to meet, and it is improving, and actually the improvement is linked, because if we see our patients faster right at the beginning at the front door of their journey, that makes the 12-hour easier to meet in the early part of the journey, as well as the 4-hour. So I'm not saying that, never is there a rush at 3 hours and 45 minutes to move a patient to the next stage of their journey, but an appropriate rush rather than anything else.
Okay, that's great. Thank you very much. Finally, the fourth quadrant was about people. I don't know, Janet, if you had any comments specifically on that aspect of the IPR over and above what you've already talked about.
Not really. I think the only other thing I was going to say relates actually to the committee report, similar to
okay,
Richard,
which
so
we'll
I'll
come
leave
to.
that for then. Yeah.
Okay. Any questions on the IPR from anyone? No? Okay. Richard.
Yeah, sorry, small one, and I note Adam's remark about sickness, which I appreciate. But the thing that concerned me most was the increase in the mental health and stress-related side of sickness. And I wanted to understand, do we understand that better, and what are we doing about it? It's more of a fundamental concern to me than the absolute percentage.
Who'd like to come in on that one? Right, Penny. Yes. Okay. Yes. Okay. Penny.
Sorry, I was struggling to find the electronic hand, so I thought I'd put the real one up. I think you're absolutely right, Richard. It's something that we've talked. I mean, I've been here 2 days. I'm using this term broadly, but in the 2 days I've been here, we have talked about the amount of perhaps the amount of change that the trust and other trusts are going through, and how we continue to manage that effectively while running a business. So it's parallel tracking. I think, to answer your question, does more work need to be done to understand the root cause and what we can do to support staff? I think the short answer is yes, we do need to do well. I certainly do. But I know the team are on it already. I think there's things that are in train already. We're trying to nip things in the bud as much as we can. But I think there is probably a refreshed, or the need to refresh our view on how are we going to deal with the period that we're about to go into. Adam alluded to it in his chief exec report. Change just keeps coming. How do we continue to run an operational trust while dealing with this? And I don't have the answer right now, but it's something that's certainly on our radar. It's on the team's radar. Perhaps I'm meeting Janet later. Perhaps we can talk about that just in the people space, and then bring back a fuller answer to that, because I think it's a very fair question.
Absolutely it is. Teresa.
Yeah, just to say in support, I think what Penny was saying there, a lot of work has been pushed forward by our ward managers, 26 of them, sometimes more, meet every Tuesday, and they're really, they're providing an invitation to say, let's try and lean into some of the difficult stuff and find some solutions. But they are absolutely highlighting, how do we get our sickness policy modernised and trained with modern thinking? How do we make sure that you know, that our sort of health at work is working in line with best practice standards, because we've got great people in all these touch points, but it is about just trying to bring it into a different level of focus. So I feel really confident, certainly from the nursing perspective, that the ward managers are saying, let's work together on this with colleagues in HR, let's find better solutions, whether that's looking at shift patterns, looking at sort of ways of trying to create better well-being for staff who are perhaps feeling under pressure, and also clearly having senior teams out and about in all the clinical and non-clinical areas, of course, supporting, understanding and walking in the shoes of the staff.
Okay, thank you, Teresa. Okay, so we'll come to the end of our discussion about the IPR. Thank you to everyone for their contributions, and especially thank you to Lucy for presenting the IPR quadrant today. I think you did a great job, so thank you for that. Right, if we have no other comments, that was for noting, I think, so we can move on to the committee reports. David, quality and safety, and I think you've got 2 meetings in your report, haven't you?
Yes, I have, and I think it's all there. We did touch upon fire safety, and there's a summary there in my report. I suppose the other comment I particularly want to make is around data in maternity. You know, for some time historically, we've been wrestling with the changes that when we moved to K2, and what we're hearing and what we heard particularly in the last 2 meetings was there are still gaps in data and gaps in data quality around maternity since the implementation of K2. And I attended the One EPR First Governance Committee on Monday, and I think I just want to reflect out loud how we implement these new pieces of software, but the consequences can run on for a long time.
Okay, thank you very much. The report is there. Hopefully everyone has had a chance to look at it. Any questions or comments for David on his report? No? Thank you very much, David. The report was very clear, and thank you for your reflections about K2, which I've heard concerns about that one from other people as well. Finance, planning, and performance and planning, whatever. Richard, whichever way round the P's go. Richard, over to you.
Thanks, Anita. I mean, a lot is in the report, but I'd like to emphasize maybe a few things. So first of all, on the positive side, we've talked about the UEC performance, urgent care performance, and we were quite impressed with the improvements we've seen. It's now 4 months in a row, which is really positive. It was one of the really hard and tough things to address, and we believe we're on the right trajectory. We haven't changed yet. This is the assurance rating, but I think that's imminent if this continues. So that's really positive. Secondly, on cancer, June was a month where we really hit all of our national cancer targets. Cancer has had a good performance all year, so this is just, let's say, a confirmation of how they're doing. So these are really positive things I'd like to highlight, and probably also feedback the compliments to the teams. In terms of the concerns that we've got, clearly the biggest concern is around our financial plan. 2 elements into it. One element is, do we really deliver on RTT? Because that's related to the block payment. We've got an RTT assurance and delivery plan on the agenda of next FPPC, which is kind of the mechanism to assure ourselves. The second one is still the gap in identifying the 35.6 million of SIP, and there's still a 15 million gap that needs to be identified, which has the focus of the committee too. And then going back to Jill's earlier question, we've asked Martin to, as soon as possible, do a proper year-end forecast process to identify the risks and opportunities to kind of be on the early side managing this going forward. And then finally, there's mention of the One EPR program in the board report. We had the first meeting this week of the new One EPR task and finish group, which was really good. And the phasing that's mentioned in the report will change, but we'll come back to that in due course.
Thank you very much, Richard. Any questions or comments for Richard and FPPC? No, thank you very much. And interesting, your comment about one EPR. We'll take it offline, Stuart. But if that committee is becoming a full board committee, we probably need to going forward have a committee report in the section here as well. But we'll address that one offline. Lucy.
Just to sadly pick up on the resident doctor industrial action, they've just published a plan for a 5-day walkout between the Friday the 25th of July and first thing on Wednesday the 30th of July. So we are in planning mode for that already, but yeah, that's just been announced while we've been talking during that item.
Thank you very much, Lucy. I think we were, since yesterday, we've been expecting something like that, but yeah. Okay, thank you very much. Right, moving on then to people and culture, Janet.
Thank you. Just a couple of key points really, and it relates to the sort of the SIP and what we're doing around really kind of trying to achieve some of those targets. There still remains a bit of a gap in terms of the oversight of the People and Culture Committee in relation to the equality and the equality impact assessments. This is an area where I'd really like to see more sort of cross-fertilization, if you like, because I realise those are seen through the finance performance side of things. So just a bit of a plea that we can have sight of that process and kind of understand how that's working, so we can be helpful really in terms of the people side of it and making sure, you know, picking up on Richard's point about the sorts of sickness we're seeing, really just understanding what we need to be doing to mitigate that. And then related to that, the chairs committee meeting that we have, there was a discussion about the crossover in terms of a people person on the finance side and a finance person on the people side, and while I think they are reflected in the terms of reference, attendance is a bit sporadic, so just a bit of a plea on that one, really.
Thank you very much. Any questions or comments for Janet? No? Okay, thank you, David, Richard, Janet, for your reports. Let's move on then. Well, we've got the system performance report in there. I don't know, is that Martin normally? I think we normally just take it as for noting. Was there anything Martin or anyone wanted to say about that report?
No.
That was short and sweet. Okay, fine. Thank you very much.
Sorry, Anita, I would just highlight, if you look at the exec summary, the data being published is in February and March 25. So you can see it's last year's data. So I think we should probably take a view outside of the meeting whether actually keep bringing this forward is adding any value, or whether we just circulate it for information outside of the meeting.
Yeah, absolutely. I think that's always been it's always been so out of date that it has limited value for us. But I guess interesting in terms of trends. But that's about all. Right. Thank you very much. Let's move on then. Audit and Risk Committee, Karen.
Okay, I'll be quite brief, but first of all, we did have an unqualified audit opinion issued on the 29th of June, and we were really delighted to receive that in accordance with the deadline. And I did want to acknowledge all of the work and effort that has been put in by the finance team to actually achieve that deadline. So really grateful for that. The auditors at the same time did also produce their annual report. It is the first time for a while we've had the annual audit report at the same time as the audit opinion, but it means that it is so much more timely. And there are 3 heads in there. I've attached it to the report, which I think it would be good if all board members had a read, because it covers off our governance arrangements, our arrangements for financial sustainability, and our arrangements for achieving economy, efficiency and effectiveness. And the bulk of that is really, really positive. There is one area that they highlighted as a significant weakness. That's an area which we are extremely aware of as a board, and that is to do with financial sustainability, when you actually read the report in detail, they were quite complimentary about us as an organisation in terms of the fact that we met our financial targets last year. And I think because we are so focused on the future and the current SIP targets, it's very easy for us to forget that we actually did break even and we made a small surplus at the end of last financial year. The key area that they were targeting is our SIPs, and that is because quite a proportion of our SIPs for last year were non-recurring. That is something that as an organisation we've been really concentrating on, and much of the plan for SIPs this year is there is an increasing proportion of SIPs that recur across the year, which will be much more sustainable into the future. However, as Richard highlighted earlier, we do have a gap, and that is the point that the external auditors were making in terms of we have an amount of our SIP this year which we don't actually at this stage have really concrete plans worked up for. Having said that, for other plans within the SIP, we've made some big changes in processes, again highlighted by the auditors, in terms of having project plans, etc., in place. So I won't say much more than that, but I did think it was really important to highlight we've had an external audit of these areas, and there are some really important things within that report. Thank you.
Thank you, Karen. And I'd completely agree. Having read a few of those reports and VFM audits in the past, actually, and given the climate we're in, I thought that was actually an extremely positive one. I imagine there isn't a trust in the country that doesn't have financial sustainability on there, as highlighted. You know, I'm afraid that's where we are. Clearly, you know, the SIP, in particular, I think for me, the identification of the missing SIPs, I think, is the thing that would make me feel a little bit more reassured. But I know the team are working hard on it. But absolutely agree, it was actually a really good report from the auditors. Great to get an unqualified opinion, and absolutely echo your thanks to the whole team. You know, the amount of work needed by the finance team to get to that point is not inconsiderable. So please, our thanks and congratulations to the team for having reached that point. Thank you. Any questions or comments for Karen on her report? No? Okay, then last report is Nina, Charity Trust.
Thanks, Chair. So for the Charity Trust this year, we are developing a slightly different strategy, and it's increasing connection to the cause. And so the vision is constant. So we still want to be the go-to charity for residents of Hertfordshire and the surrounding areas, but we're really pushing this idea of connecting the community and also obviously the hospital community more widely to the cause. And in connection to that, what we noticed is that there are more funding requests coming through from Mount Vernon rather than the other sites. And so we are also looking at how we encourage staff and maybe change the way that we apply for different things to make sure that people know that they can access some of that funding, and also to feel a bit more confident in filling it out as well, because we noticed that there might be some barriers in terms of people feeling comfortable enough to fill the forms out, although Ellie has made them incredibly easy. And we added a new Twilight Walk, which was a 5-mile walk around Stevenage, and it was to raise funds, but it was staff and patients that had breast cancer that were walking together. So that was a really lovely thing that we did this time round. And obviously I can't miss out the amazing run that Lucy and Justin did as well for the colour run. So congratulations to both of you. I think you did a great job. And, you know, I'm still trying to get Janet to jump off or at least abseil off a building with me next year. So we'll see how that goes. But it'd be really great if any of the other execs fancy doing something, you know.
Or non-execs. Or non-execs.
Or non-execs,
yeah,
exactly.
I have promised I'll do that, Nina. So just
yeah,
so you heard it here.
I'll be herding you down that building, don't worry.
Brilliant. Okay, thank you. We didn't have a written report this time. Is that something that we'll get sorted for next time?
Yeah, sorry, just the unfortunately with other stuff that was going on in my life, I just had a very short window this time round. So I promise next time round it will be in.
That's no problem. A verbal update was absolutely fine. Brilliant. Thank you very much. Any questions or comments for Nina? Nope. Okay. So thank you very much. Annual cycle is in the pack for noting. Does anyone have any other business that they would like to raise? No. Okay. Then thank you. Oh, Tishafara. You're on mute. Thank you.
Thanks, Chair. So I was just looking at the annual cycle, and the conversation here today discussed the matter of getting the one EPR to be a full committee. Maybe we might want to relook at the annual cycle in view of that.
Thank you for that reminder. As I say, we need to have that conversation. I don't think a final decision's been made, but I think, and also whether we need to expand its scope to digital in its whole and all that sort of thing is still to be discussed. But absolutely a good reminder as to when we get to that position. So thank you for that. Right, if there's no other business, our next meeting is on the 10th of September, face-to-face at Lister. Thank you very much to everyone for your time today and your contributions. I think it's been a good meeting. Thank you also to anyone who's watching us online. Glad you could join us and look forward to you joining us again soon. Thank you very much.